welcome to Honor Health Medical Center in Scottsdale. First, from Bob Riley, Bob Burke, and I would like to say to all of our colleagues around the country during this very difficult time, our thoughts and especially our prayers are with all of our colleagues, physicians, nurses, patient care technicians who are fighting this invisible enemy, the COVID-19 virus.
Thank you.
We're performing a TAVR case. This is a patient who clearly had progression of symptoms, and so we made the philosophical decision that this patient needed to be treated at this time. I'm going to give you a brief history on the patient. Could you show the presentation? This is an elderly gentleman, 79 years old, with severe aortic stenosis. You can see the valve area and the hemodynamic measurements. Clearly, he fits in with performing transcatheter heart valve implantation. He has a history of hypertension, clear symptomatic progression over the past 2 to 3 weeks, and we did perform a cardiac catheterization, which really showed no high-grade or focal epicardial disease. Bob Burke, you vetted this case. You spent a lot of time vetting this for us. Could you tell us what you saw? Put the confidence monitor back up.
So what we saw in this case with CT is that he definitely has a very calcified valve from the standpoint of the leaflets. There's really not much in the way of annular calcification. Coronary heights are excellent, as is sinus of Valsalva volume. With this being said, he'd be a candidate for a 27 Lotus Edge.
Okay. So there's the sinus of Valsalva that Bob talked about. Go to the next picture. Coronary heights, great coronary heights on this case. And then the multiplanar. Bob, could you review the hockey puck again?
So again, you can see that this is a tri-leaflet valve, definitely very calcified on the leaflets and mostly leaflet tips, more so than anything else.
Next picture. There you go. So, Bob, I think, Bob Riley, we do balloon valvuloplasty a fair amount, especially with the Lotus Edge. That's been our tradition. Looking at the multiplanar there, you agree with doing a valvuloplasty on this one?
Right. We'd like to valvuloplasty our Lotus Edge patients beforehand, since it helps with the locking and deployment of the device, more reliable locking.
Mm-hmm. So what we've done thus far is we have transradial access. We do not use transfemoral access on the left side very much. We've gotten used to transfemoral on the right for the delivery of the valve, transradial on the right for the delivery of the guiding pigtail catheter. Bob Riley is going to take us through the use of the MANTA device for vessel closure at the end. We've gotten somewhat away from suture-mediated per-close or pre-close on these cases, and Bob, you'll take us through the MANTA device. And then finally, we have we'll use a 15 French eye sleeve for the purposes of delivering this. We'll discuss that a little bit more. And then also use the extra small safari wire made by Boston Scientific. Okay, at this point, we've decided to use a 20 by 4.5 true balloon by Bard for the purposes of our valvuloplasty. You can see we have our extra small safari in the ventricle, got a nice quiet rhythm at this point. Our pigtail is in the non-coronary cusp as we demonstrated. Now we're crossing with the balloon. Our anesthesiologist is going to juice the pressure a little bit for us.
Move to our new implant angle, please.
Okay, Schwartz, we need a little more pressure there. Thanks, Bob. Thank you, Bob Burke.
I'm going to hover above the valve until the pressure comes up.
Yep. All right, good. Ready? All right, so Dr. Schwartzstein, why don't you bring down the lungs and start pacing. Mag up one, please.
Mag up.
Okay. Okay, still a little bit of movement. Stop pacing, bring down the lungs. bring up the one, sorry, what we're doing.
So come down to the tip of the eye sleeve. So we want to make sure that the balloon is fully deflated, obviously, and then we want to make sure that we do not
It's not.
bend or invaginate the tip of the eye sleeve. We want to keep it.
You can see right there that there's still some profile to the balloon, so I'm just giving another negative pull on it. So go ahead, Bob.
So you can see it just kind of barely interacts with the tip there.
That looks great. I think what I like especially about the eye sleeve is the consistency with which we've been able to use this.
So at this point, when we advance our valve through the eye sleeve, we will need to keep it well lubricated. And we will actually inject through the side port of the eye sleeve at the same time.
So Bob, what I'm going to do is just hook up this saline to the side port, and as we advance, Tracy will inject. Tracy here will inject into the eye sleeve, just to make it very lubricious, if you will. Okay. Now, one of the things that we do is we make sure there's a lot of really sloppy, wet 4x4s on our field. I think the only mistake you can make is not lubricating all of the equipment enough. Do you agree, Bob?
I agree. So at this point, we have our Lotus Edge in an S-shaped configuration for access in the right groin.
Yeah, could you possibly show that so you can see what we're talking about? So what Bob is saying is, when you go into the right side, the standard methodology for implantation is that this delivers in an S shape. If we were implanting from the left side, it would be a 2 or question mark shape. So, and we're going to try and maintain that shape as we enter the eye sleeve. Go ahead, Bob.
After it's loaded up to this point, we do check to make sure that we're not oversheathed or undersheathed, and I can fit about a fingernail and a half here. It's within the range of normal. So we want smooth, long passages here. Inject.
Control the wire on the back end. No, I got this. I got this. Just control this here.
All right, here we are exiting the tip of the sheath. It's split, and we have no problem there.
That's nice. And Bob, look what you've done.
Injecting now.
Bob, just so you can see, mag up, please. Mag up one, please. Tracy, come this way. Mag up. Now look at what he's done. We're fortunate. You see that dot at the in the middle of the delivery of the valve? That dot is going to be on the greater curvature. That's what we want to achieve. It looks like you may have already achieved that. When we come up and over, Garrett, I want you to go to an LAO view. Bob, go ahead and advance, please.
Unmag for us and come up to the arch. 30 LAO.
That's perfect. Yeah, you've already done a great job of getting that on the greater curvature already. That's perfect. That's perfect. And you can see sometimes there's an interaction of the pigtail with the catheter when we're in the radial position with the pigtail, but this looks like we're doing pretty well here.
Let's go to our implant angle and mag up twice, please. So we just crossed the tip of the native annulus, and then we'll get into our angle. We'll move the echo probe back and center that for us.
Little pressure, Schwartzy. Bob, say that again.
So we just crossed the tip of the annulus before we got into our implant angle or our deployment angle. And one of the keys to the Lotus Edge is to try to avoid a deep implantation here.
Bob, we need to get this pig down there.
I think that we're okay.
No, it's high. Inject, please.
It's right
Maybe
at
you're
it,
right. Yeah, okay, good.
So let's do a dry cine run here to define the anatomy of the device.
So you can see there are the buckles and posts, and what's going to happen is as we deliver this, we'll bring the buckles and posts together for the locking mechanism. We'll show that as we go along. Bob, how do you like your depth at this point?
So right now we're going to put the frame of the valve just at the annulus, and then as we start releasing the valve, it will dive deep, and then I want to keep it somewhere between 3 and 4 millimeters deep.
Could you mag up, please, and give me more fluoro?
pull wire a little bit, please?
Yeah.
Wire does not aid in positioning of this valve at all.
I think that's an important point. In contradistinction to core valve, we're not using the wire to position. Now, Bob, I kind of like where we're at. I think we should start unrolling this. If you can mag up on my hands, there's this bluish green turquoise dial, and I'm going to turn this counterclockwise or toward me, okay?
And it's a very controlled release here, and in between twists, he will let go so there won't develop any stored tension. And my job in position 1 here is to kind of keep it in the spot that we want.
I think you're doing a magnificent job, Bob. And what Bob is doing, you can see those buckles are sort of parallel or next to the pigtail, at least at this point. We are looking at braid frame density, a little bit of a dive. Give me a toot on the pigtail. Okay.
Let's pace at 120, please.
Yeah, and I think that's a great point. Never be afraid to pace, low-grade pacing with this, just to keep it from moving to and fro between the ventricle and the aorta. Okay?
Maybe 130 so you have better capture. Pull wire a little bit.
There we go. Okay, Bob, I'm going to start unwinding this again. Give me a little toot, please. There you go. Perfect. I love your depth right now. Love your depth. Love what you're doing. And I'm just very slowly, very controlled expansion of the device. You can see the black marker. That black marker is the top of the polyurethane adaptive seal, which is one of the hallmarks of the device in terms of prevention of paravalvular leak.
Slow down your pacemaker, please.
So we have contact, you see, on the one side, on the right side of your screen. We have contact on the left side. And now you can see the buckles and posts coming together. So what I'd like you to do, if you would, is go a little bit cranny. Now, we have several ways of bringing the buckle and posts together. And one is by me continuing to unfurl this or move counterclockwise. And if we are meeting some resistance, which rarely happens, Bob can do a push-pull technique and bring those together. You can see they're coming together very nicely.
I'm laying over as we speak, and the combination of that just
Look
brought
at that.
them all
That's
together.
beautiful. Just fluoro save that. That's great. You can see what he did. I'll do a cine here, but those are locked, those buckles and posts. And here's the beauty of the device to me. We've been carrying on a very comfortable, casual conversation, describing what we're doing. The hemodynamics look good. We do not go through that phase of hemodynamic instability. The valve functions early, so we don't have that hemodynamic instability. This is a very relaxed, controlled expansion. You can see...
And look at the echo findings.
And look at the echo findings. We have been cognizant of our coronaries. Can we just do a picture here and show this relative to the coronary heights? I think we're in good shape there, and we have a fair amount of sinus volume, so I'm comfortable that we would be able to access the coronaries in the future. And because of the repositionability, it has one of the lowest valve-in-valve rates across randomized trials and across registry trials. So that's another plus to the device. I think the real plus here, Bob, is look where the dot is compared to your pigtail, and that's the top of the polyurethane adaptive seal. And that looks like it's in a perfect position to prevent PVL angiographically. And Bob Burke, what are you seeing fluoroscopically, or on echo?
On echo right now, it looks perfect. So we're seeing no evidence of any PVL. There is a little bit of central regurgitation, which we see with the wire itself. Mm-hmm. We're seeing that the left main looks very well preserved right here. So if we take a picture, you can see flow into the left main, and we can get rid of that. We've got several millimeters here of space between the device, about 5 millimeters or so between the device itself and the opening of the left main. So definitely safe in that regard. This all looks great.
Bob, you want to comment? We always look at the braid density and the symmetry of the braid density. Do you want to comment on angiographically or fluoroscopically what you're seeing?
So the braid density, we look to see if we have early capture or early attachment to the anatomy. It also will indent where there's heavy calcification. But it turns out that it does not affect the valve function. The valve moves independently on those tuning forks and not attached to the braid frame. But we do use it to help with our depth. We do use it to judge our coronary height and our re-access ability, like you just mentioned. And then in this particular case, we have a very even distribution. We do not have it flared at the top or bottom or mushroom topped, like we would say, or champagne glassed. So I think this is actually great.
I'm going to land this thing, okay?
So
Want to demonstrate a TIG test just because we don't have much
Okay.
of a waste?
All right, so Bob, let's do this just before we land this. Let's do a tug test. That's Bob. He's going in.
here's the push,
Here's the push.
and here's the pull.
And one of the beauties of this device is once it's locked in, it's generally locked in very well. One of the real upsides to this valve. Now,
So I'm going to pull the pigtail while we do this.
so I'm going to move this to end of travel, and then you'll see a slight separation of buckle and post eventually.
Sometimes we see it more than this.
Yeah, exactly. Okay, zoom in on my hands if you would, please. Now, this black device here is the collar. I've been using this device in counterclockwise fashion. I'm moving the black collar forward, and there's actually, if you can get in here, there's actually a pause sign on this. So when I match up these dots with these markers or dots here, it's very intuitive that that's as far as you want to go. And what you're going to see is the release pin. There's a release pin in the center of this.
So let's move that off so that people can see the pin. So come right or left. Go live. There you go. Stop. That's good enough. Go back.
Okay, now you can see that release pin pretty clearly. So I'm not going to look up, I'm going to look down, and I am moving
And
this.
it just released, and now it's pulled all the way back. And the posts stayed in position.
Now
It
we
is-
see that separation.
And none of the posts dropped or are floppy, so we know that the valve clearly is locked.
So Bob, let me comment on that. As long as you lock this correctly and do the steps that we did in a very controlled fashion, I just have never seen the floppy posts. I've seen other cases, but we've never had that, and we have a high volume of Lotus cases. Locking it properly really does prevent that, doesn't it?
So we are pretty compulsive about that, and then we do the push and pull test. And I think that we might have some advantage in we lock just as much with the handle as we do with positioning.
Yeah.
And so we double check and triple check to make sure that we are locked. So you're right, we've never personally experienced a flail post.
So I'm going to go to end of travel here on this, and that end of travel is going to release those sheathing aids. There's
And they
9
just
of them.
have.
Okay. Now, what Bob is going to do is just like removing a pacemaker, a temporary pacemaker that we put in the operating room. Bob is just putting
Unmag, please.
Bob is just putting a little bit of tension on it, and he's using that to release the sheathing aids, let the cardiac cycle release those sheathing aids. There we go, and there it comes off. Now, we are going to capture the device. Those sheathing aids, Bob, you've commented before that they're not particularly hard sheathing aids. They're very soft material.
They're very soft, even though they may look sharp. They're very soft and flexible. They're not doing any damage to the aorta, but we do want to do as little motion as possible here. We'll just keep it in this position, and as you recapture, we'll let it withdraw into the sheath itself.
And this really, the nose cone really does not have any significant interaction with the device. It's a very blunt nose cone, and you can see how easily we're retrieving it. We're retrieving it in the ascending aorta. We want to be careful not to oversheath.
Now we'll pull it to the descending.
And we want to watch this go back into the eye sleeve. If you could push away.
Pull wire in.
Yeah, so we can see the eye sleeve.
So the device does have a fair amount of stored energy. So if you look at the sheath and the nose cone, we are hanging out about 3 or 4, maybe even 5 millimeters on one side, but the stored energy will pull that in a little bit more. So we don't want to oversheath that, want to be very cognizant of that. And that passed through that eyelet there without any problem.
Boy, that was beautiful.
And then there you are.
Yeah. Okay. You can take this out. So the next thing we're going to do is Bob is going to demonstrate the pulling of the 15 eye sleeve and the use of the Manta device. We're really excited about this device. I think you can think of it as as an angioseal on steroids. It's a larger, bulkier angioseal, and generally works on the same principle as an angioseal. That is not to say that suture-mediated per-close and pre-close fashion is being replaced. This is a device that we've been using with great success over the past several months, and we're pretty excited about this.
Holding his leg down a little bit. So now when we pull the eye sleeve, we want to do this over the wire with the dilator in place.
Tracy, would you demonstrate for us how this is placed into here? We take this blue inner dilator. Go ahead, Tracy. And now we're going to place it inside the catheter and a quarter of a turn, and it locks it into place. I want you to zoom in on that. Okay, perfect. And when we put it in, the side that says 18 French, that's going to be the side that's up. Bob, I'm going to pass this for you.
So the device does come in 2 sizes, and we prefer the 18 French for the expandable sheaths. So this gets hubbed, and then we'll unlock the dilator, leave the wire, and pull the dilator out.
That's a really great one-handed technique you're using there,
You
Doctor.
taught me that. Thank you.
Doctor.
Yes.
All right. So, Bob, you want to talk about the just being careful about the blood dripping back from that?
Yeah, the hemostatic valve does get altered by the J wire, so just try to keep it centered. If you use a stiffer wire, it's worse, so we just use a regular 035J.
All right, as I hand this to him, why don't you zoom in on this? As I hand this to him, you can see that I'm placing the wire inside the lumen, and what's going to happen is there's a little sort of a guide, I call it, this white catheter that's going to come back, and once the wire is through there, I'm going to take this little guiding piece, pull it off, and then with this side up, Bob is going to place that. Go ahead, Bob.
I'm going to grab only the introducer here and inject that first, and then I have to advance this. It locks on both sides, so you double click here.
So I'm going to step back. Bob, I want you to describe what you're doing, sort of the color coding. I'm going to step back so that they can zoom in on that better.
Okay, so at this point we will ask for what was our depth? 4 plus 1. So I will slowly pull back, keeping neutral tension on the skin till 5.5. 4 plus 1, pull back to 4 plus 1 or 5. So I'm at 9, 8, and I just keep making sure that the skin is not being tented. 7, 6, 5. And you do not want to overdo it because you cannot go back in. So at this point, I will open the foot pad here. I will raise my hand to 45 to 60 degrees, and I will pull back until this little window has the green-yellow portion. It will bleed when we do this, So I'll pull back fairly quick, and then when I get to that point, I will use the inner sheath to tamp down the plug.
I think that's an important point, Bob. It is going to bleed a little bit, but you just expect that.
So there's green, yellow, tamp it down, and then pull back to red. Release everything.
Look at that.
And lay it down.
Wow, look at that.
So
That is
we
beautiful.
can reverse our heparin at this point, and just hold a little bit of manual pressure for the track.
Can I ask you how easy that is?
Once you get over the amount of bleeding and you realize you just have to kind of pull in an efficient manner, it's very easy.
So you just have to be comfortable with that amount of bleeding that you have during the pullback, but that's really the only uncomfortable piece to it, and that's really something you just get used to.
And I did that fairly slow for the camera today, so it's not even that much when you
Right.
do it off camera.
Right, right. All right, I'm going to step over here. Bob Burke,
Pardon me.
can you join me? Bob, any problems with the leg? It looks really like you're doing just, look at that.
Nope.
That. You want to talk about drama-free. That was pretty easy. So, Bob Burke, could you join me over here while they're just, the groin looks fantastic, everything's going well. So,
Just hold it while they're doing it.
tell me, Bob, what you have learned from transesophageal echocardiography. We use a fair amount of TEE, especially when we have newer devices, and this is still relatively new. Tell me what we've learned from transesophageal echocardiography.
So what we've learned from transesophageal echo, specifically for TAVR, is really how much is happening dynamically during the procedure. We didn't realize that we could get into trouble with interacting with the chordal apparatus, with the mitral, with something as simple as putting the wire into the ventricle to begin with, and then dynamically seeing what happens with these valves over time. It's interesting because from the standpoint of paravalvular leak, particularly with repositionable valves, we've seen that you can initially have some degree of leak, which will actually improve very quickly. This can happen over a matter of minutes in many cases. And when you can reposition a valve, being able to really redirect where we should be landing the valve. Sometimes on fluoro, it looks like we may be too deep or too shallow. On echo, we can really dial that in much better because we see it in real time exactly where the valve is actually landed. So I think that's helped us a great deal as far as deciding, okay, we've got some PVL, are we too deep? Is that why we're not sealing? And being able to readjust on the fly.
Boy, that's really a great description. I know we are moving toward minimalist TAVR, so it's very popular to maybe use surface echo, if any echo, but I think there's still some incredibly valuable lessons to be learned with the use of transesophageal echocardiography, and we're blessed to have such a robust program here.
Well, I think the most important thing with TAVR is that particularly as we get into lower risk patients, the need to have technical perfection is really important. I think that our goal is not just can we do the procedure. I think that we've proven as a nation, as cardiology in general, we can do this procedure. It's doable. The issue that we have is making sure that when we do the procedure that we get the best possible results that we can to really emulate what we see with surgery with no paravalvular leak or at least minimal paravalvular leak. And again, that's one of the biggest issues that we have that favors the Lotus Edge is that we have the ability to reposition. We can confirm on echo that there really is no paravalvular leak and go from there.
Okay, so we've talked a lot about the polyurethane adaptive seal, and I think the way to think about that is the device initially goes in elongated, but then as you deploy the device, it sort of scrunches up like the sleeve on your shirt.
Exactly.
and forms, it bunches up, and that's how that adaptive seal prevents paravalvular leak. Now, what we see in the randomized data, I think, is just spectacular. In the randomized data, at the time of implant, your paravalvular leak rates, if you look across randomized data, randomized trials and registry trials, you're sitting the moderate or greater PVL, which clearly has an impact on long-term outcomes. you're sitting about 4 or 5%. But by 3 years, we presented the 3-year data at TCT this year. By 3 years, the moderate or greater PVL is about 0.7%. That is a dramatic difference to me in terms of when we compare this device to other devices with respect to paravalvular leak. I think that is, I mean, there are differences that I've never been able personally to explain in terms of stroke rates and everything. It's compelling data, but we've never been able to explain why the stroke rates are lower. But we do know this. Valve-in-valve deployments are extremely low because of the repositionability of this. Coronary access later on is very favorable because of the repositionability, but especially the PVL rates at 3 years, less than 1%, and that really compares favorably with other transcatheter heart valves out there. Bob, can you come over?
Sure.
So, yeah, give us a. So Bob, give me your sense as a surgeon who's really very used to minimal, if any, PVL when he's done with a surgical case. How does this impact your decision making in terms of choice of valves? I mean, I think this was dealer's choice. I think any of the valves would have worked very well in this particular case. You could have chosen any of the balloon expandable or controlled or mechanical expansion, self-expanding valves. How does the PVL rates impact your decision? You're really used to zero PVL.
Right. So I was listening to your conversation, and what Dr. Burke said is very true. Settling for PVL of any sort in a low-risk person is really something we should avoid. So I think this valve does an exceptionally good job at avoiding PVL. I think it does a very good job at preventing PVL in heavily calcified valves and ones that we would predict would be high risk with other types of deployments.
The one recurring take-home message that I try and share with audiences when we do these cases is that there are a lot of new operators out there, young operators, intermediate experienced operators. This is not just a valve for your complex calcified bicuspids. Yes, this valve does very well in those settings. To me personally, I think this is a first-line valve. You saw the ease of deployment with this valve, and because it was so easy to deploy, I think young, new, intermediate level operators will find this a valve that they could and should have in their armamentarium of valves on the shelf. I think we, as a group, we have a fantastic group of nurses and patient care technicians and physicians in the room. I think we made this look, as the expression goes, like a drama-free TAVR.
So I will comment on that a little bit. I agree, it was drama-free and it went very well and smooth, but I would caution young or inexperienced Lotus Edge operators that this is not a one-person procedure. Mm-hmm. So there is a lot of teamwork and interaction here, and when you do get on the same page, it is very smooth. But you definitely need 4 hands for this procedure.
So what you've seen in terms of our interdisciplinary approach, a lot of emphasis on what our echocardiographer is telling us both before the case and in real time. A lot of great experience on the part of a surgeon who really has taught us so much about valvular heart disease as we've matured as an interdisciplinary group. And certainly it requires catheter-based skills that we share with each other. So I love the interdisciplinary approach to what we're doing with this and our team in general. Bob, would you care to discuss some of the aspects of depth of deployment on this?
Yes, so one of the things that has been a concern with all TAVR valves, and then initially with the Lotus valve, was the depth of deployment being associated with pacemaker rate. So we've been very conscious over the last year of how high we implant these. And in fact, as you notice, the Edge allows that to happen a little bit better because it does not dive deep into the ventricle. And we made a very concerted effort in position 1 here to prevent that from happening in the entire case. So by having a shallow deployment, we still had a great seal, and we had no PVL and also no altercation in our electrical conduction.
I think the depth guard, which is some of the proprietary technology associated with this, really, really helps. Bob, hemodynamics. Tell us about your last TEE images. What are the hemodynamics that you found at the end?
So our final results are excellent, with a mean gradient of 9 millimeter mercury, calculated EOA of 2.4 centimeters squared. There's no PVL whatsoever, and as you notice, there is no change in the QRS complex, no prolongation of the PR interval. So across the board, this is fabulous.
And this is going to serve this patient well as we look into the future.
Oh, absolutely.
And remember, that's no PVL on TEE.
On TEE. That's an important point. We've used the best imaging technology possible to prove really no TEE. I think that's great. I think this is a patient in this new minimalist world that we live in. I think this patient, all things going well, once he comes out of here, he'll go to telemetry, and he should go home tomorrow. Do you guys agree?
Yes.
Absolutely.
All right, we're pleased to be coming here from Honor Health, and again, on behalf of our entire team, our thoughts and prayers are with our colleagues all over the country as we together battle through this pandemic. So thank you very much for joining us.